And so, hello everyone. Welcome to the Meaningful Use and PQRS webinar. This is another in the series of free webinars that Phasis Group puts on for all of its clients. We're hoping to hit topical items that will hopefully mean something to you, and along with having it geared towards how to use CareTracker to facilitate whatever the issue is. We also want to impart just some general information. And Jenny, you might, if you can, would you go ahead and mute your phone?
I don't know how to do it on this one.
So up on the screen, the little GoToMeeting screen, there's kind of a picture of a phone, a little green thing. If you just click on that, it turns red and you're muted, and then you unclick to get it going. And it looks good. Thank you, Jenny. Appreciate it. All right. So today's webinar is on meaningful use. There have been some changes that have come down the pike recently, and we want to cover all of the objectives. We are also going to look at kind of the timelines that are affecting you this year as well as next year. We want to look at all of the objectives that are outlined. Those are the individual items that you're going to have to meet in order to successfully attest to meaningful use for the year 2015. And then we're also going to go into CareTracker, and Brad is going to show you for each of those objectives what exactly you need to do, how you either configure CareTracker or how your workflow supports triggering the items that will give you enough successful cases to be able to attest. We'll talk about the tools that are there, and we'll also talk a little bit about, within each objective, any workflow that you might need to adhere to in order to meet the thresholds when they're measured. We're also going to talk a little bit about PQRS. We're going to give you an idea of what the overview of just what PQRS is, and we're also going to give you step-by-step process for you to successfully report your PQRS data for 2015 and avoid the 2% penalty that hangs out on that. Lastly, we'll also discuss the clinical quality measure reports that are embedded in CareTracker that are essential to both meaningful use, attestation, and also usable for other items as well. So, any questions on what we're going to cover? All righty, so let's go ahead and go to the next slide. So, meaningful use final rule was just released October 6th. Originally, 2015 was supposed to be a 365-day attestation period, which means that anything that was being measured with thresholds of 10 or 20 or 30 or 50 or 60% was based on 365 days worth of data. The recent rule changed that. It's now only a 90-day reporting period for 2015, increasing to a full 365 days for next year. Some of the other changes, originally we had menu items and that you could select from, and there were also core measures that everybody had to adhere to. A total of 23 individual items split between the 17 core and the 6 menu measures. And so you basically were reporting 21 total measures out of the 23 that were out there. It's been replaced with, instead of core and menu measures, it's been replaced with a single set of 10 objectives. Many of those objectives have a single measure. Some of the objectives have multiple measures, and one of the objectives has multiple measures, of which you're picking 2 out of 3. So basically, there's going to be a total of 16 measures that are available in the new, or objectives in the new, it's correctly measured, 16 measures in the new rule, 15 of which you're going to have to attest to, and when you attest to those, 15 measures, you're going to have supporting evidence. There are retired measures, so things that you may have been used to doing in the previous attestation periods, like recording vitals or always checking smoking status, and they got kind of complicated. You had to have 2 or 3. There were lab results, different than lab orders. Lab results, we were always requiring you to link results to a specific order. And I just wanted to make sure that everybody understood that a lot of these have gone away. They've been retired. And the reason that they've been retired is that those were generally successfully reported on by a extremely high number, like 99% of the people attesting hit these measures, and so it was felt that it's kind of a waste of everybody's time to continue measuring that if everybody's got it under their belt. I'll warn you that the expectation is still there from CMS that these things are being monitored and recorded. So I would not recommend trashing anything in the workflow that you have in place that addresses these, but it's nice to know that you don't have to track whether or not you've got a certain threshold met or not. But the expectation underlying is there, and expect that at any point in time, CMS might pull a fast one on you, and midway through the year, they might go, oh, by the way, we're going to make smoking status required again, because we always expected you to do it, and lo and behold, here's a threshold you have to get over. So just kind of throwing that out there so that everybody knows that they still need to use CareTracker's EMR in a way that will meet old and new meaningful use requirements. The new requirements, the things that
also,
are introduced.
I wanted to let me just put in an aside there too, that for CQM's clinical quality measures and for PQRS, they're going to be running reports based on that type of data collection, and so it's another reason why you want to keep filling stuff out.
Thank you, Bradley. Very, very good point. So to Brad's point, in a lot of what you're doing for either attestation or PQRS, you're going to be submitting data that includes successful in this cases, and so it may come back to bite you if you scrap it totally. The new requirements that are being introduced that are things that you've not previously had to attest to are all centering around interoperability. And interoperability is the ability for 2 or more separate EMRs to communicate and exchange data. So there's exchange of information, there's providing electronic access to your patients, and there's registry reporting. All of these new items are geared towards interoperability. Okay, so the specific things that have changed for 2015, when we look at the revised rule that came out on October 6th, again, it went from 365 days to 90-day period. You could actually pick any 90-day, consecutive 90-day period in 2015 to report on. Most people were waiting for the rule and didn't necessarily know certain things that had to be done, so most people are going to choose Q4. If you were someone who had already got this geared up and you were doing all the things you needed to do to meet the old specifications, you'd be in a situation where you could, with the addition of adding direct messaging or a few things like that, you'd be able to go ahead and attest any period. The attestation period, the time in which you're going to actually log on to the CMS site with your credentials and go through the process of answering all the questions and providing numerator and denominator numbers and basically filling out the attestation online, that starts January 4th. So even if you were done, now you couldn't go on and attest until the 4th of January. And then you have to be done by the 29th. It's going to be leap year. It's 2016. It's through the 29th of February 2016. So it's only 2 months, not a year and a month. I'll get that corrected when we send out the slideshow. Then there are a couple of measures where you're getting a kind of a hall pass this year. They originally were set up with thresholds, and while they did cut the period down from 365 to 90 days, CMS also anticipated that with the late notice that they gave you, they may put you in a situation where you may not be able to hit a 5% threshold on a couple of these objectives and measures. So these are the ones that have to do with electronic access. These are things that have introduced new processes into the meaningful use attestation. So if it has to do with immunization registry or the direct messaging, you're going to get a pass this year, and as long as you have either the capability or in the case of a direct, you actually send one message, you're going to be covered. There is also a penalty that is going to be assessed if you fail to meet meaningful use. Previously, we've been talking about incentives, and it didn't hurt you if you didn't adopt, but it didn't give you any extra money in your pocket. And now that has switched to penalties. And I will say that the incentives were capped. Penalties are not capped. So if you have a significant amount of Medicare and Medicare Advantage, you stand to have a significant penalty, far in excess of what the incentives had been in the past. And this penalty for not attesting in 2015, it'll be assessed in 2017. Next year for 2016, if you once again fail to attest, it's another percent added on that. In 2017, if you fail to attest, another point is added up to a maximum of 5%. So, I mean, that can turn into some serious penalties, and we just want to make sure everybody has eyes wide open if they're deciding not to do the attestation process. And then I wanted to point out that there's some special rules. In addition to the thresholds that were lowered, we also have anyone who's a stage 1 provider, meaning the very first time they ever have tried to attest, you're going to get cut some slack because Medicare understands, or CMS understands, that since it's your first time, it's going to be really difficult to hit thresholds for things you haven't previously been in the loop on. So they are cutting that small section of people a break. So let's go ahead and jump into the first objective, unless anybody has any questions. Sounds good. Okay, Bradley, so we're going to, in a second, I'll move it over to you, but objective 1 is labeled protect patient health information. And when I read that, what comes to mind is, hey, we've already got HIPAA. You know, what are we talking about? What we're talking about is your local network, the servers, the computers, the laptops that you have that you store patient information on, and it may be that you only store it there temporarily while you're waiting to get back to the office, or you may store it on your network long term. The risk analysis really has not changed from year to year, and it still must address your local network, what you do in case of a disaster, how you keep hackers out, and it's quite extensive. CareTracker can supply information relative to their cloud-based part of the environment, but we've only seen a few people who have gone through an audit need that, and what we've supplied from CareTracker has fit the bill. So should you find yourself needing that, let us know, and we can get it to you. So nothing to show you in CareTracker for objective 1, because this one is 100% on your office and your office's IT support people. And hopefully you've got last year's risk analysis that you did, and you can look at it and update it. If you do not have a risk analysis performed, definitely need to get with your IT folks. When you attest, you're telling CMS that you do have a risk analysis that you've performed. Okay, the second objective, clinical decision support. This has 2 measures. Both of these are self-attestation, which means you don't have to prove that you've hit a certain number of times where you have used the clinical support intervention or the drug interaction screening, but you do need to be able to prove that you have that set up in CareTracker. So we're recommending on both of these measures that you navigate to the setup section of CareTracker and administration and take a screenshot of these. Again, measure 1 is selecting and turning on and activating at least 5 clinical support rules. And the second measure is that you have the drug-to-drug interaction screening or drug-to-allergy screening turned on in CareTracker. And Brad's going to take you through and show you exactly where to do that. So Brad, if I can, I'll hand off to you.
Sounds good. So any questions about this one? Or do people have this down pretty much? If you go to administration, go to clinical, and you're going to go to care management activation. Thinking. And you're going to choose 5 of these. There's like a page and a half here. And if you know, you're like, well, you know, for example, I'll pick on Dr. Ballard because I saw Lauren sign on. You know, he's in sleep, and none of these apply. Then you click the closest ones that you may be applicable to your practice. Okay, so that's that one. And then
so we recommend a screenshot of this very screen. So if you need to take 2 screenshots in order to show that you've selected 5, then please do that. If you haven't selected 5, look again and make sure you select at least 5. Okay, Bradley. Sorry, and then the drug-to-drug interaction.
And the drug-to-drug is so administration, clinical, and then you're going to go to provider screening. So the first one was care management activation. This one is provider screening, and you select your provider here, and you want to make sure that at least you've got. This is suppressed drug-to-allergy screening results. And you do not want to suppress at least one of these. This does this, you know, when you're prescribing, you're in the prescription module, and your health provider is filling out the fields, and then he clicks OK. It's going to be what's the reason that you want to send this prescription off, and typically I suggest there's a drop-down box, and typically I suggest picking the benefit outweighs the risk, but you can have your provider go through each one of these and decide how much, you know, they want to actually click through.
So the rule states that you must have the capability and enabled it. So that's where you want to have at least one of those that is not suppressing. In terms of whether you pick minor, moderate, or major, that doesn't matter as long as you're not suppressing everything. Thank you, Bradley.
Yep.
All right, so I'll take this back. So that is that's the clinical decision support. The next objective number 3, computerized provider order entry, also known as CPOE. There are 3 measures in this objective, all of which have thresholds that must be met. Now, for this year, there are going to be a lot of you that might fall into the, well, we didn't have 100 of these, so we're going to be able to exclude out. That's awesome, makes it easy. However, next year is the 365-day attestation, so my recommendation is try real hard to hit your hit your thresholds this year. Keep an eye on how many cases. A lot of you will have prescriptions that will definitely get you into that threshold area. In terms of lab orders and radiology orders, you may not hit that. It's kind of an interesting thing here. This is not about linking results, and this is not about tying things together, kind of the workflows that you want to have in your office to make it useful for everyone and give you some visibility into who maybe still has some outstanding orders. This is just about using the EMR to create an order. So in the e-prescribing, it's basically actually doing an encounter-based prescription and using the script writer. It is also about tying lab orders to an order, as well as a radiology order. So I'm going to have Brad show you all three of these in CareTracker. And here you go, Brad. So e-prescribing orders, lab orders, and radiology orders.
So I'm going to go to clinical today. Just as a reminder, if you want to see how to accomplish the measure within CareTracker, and I do this a lot, is I go to home screen, the Meaningful Use tab, put my provider into context, and by the way, now this dashboard is showing correct numbers. Okay, it hasn't been changed to reflect the new objective groupings, and it's still going by core measures and then menu items, but the metrics now are correct, which is nice.
The underlying reports are tied correctly, and the number you see on the screen is correct. Keep an eye on the news. They are updating the whole interface so that it matches the 10 objectives. They'll be doing away with core and menu items. So it's going to change, and as they're doing that work, it's not unlikely that from time to time something might be offline. So just keep your eye on the news. But I think the underlying message is, until it's given the seal of approval, use this only to kind of give you a bird's eye view. Run the reports. Run the reports, run the reports to make sure you're meeting it or not. So sorry, Bradley. Go ahead and
maybe we should sidetrack to show where the reports are housed. We can do that. What do you think, Matt? So,
doesn't matter. I've got it on the agenda to cover. I think I'd stick with. Let's stick with the objectives.
If you to actually see how you can accomplish the CPOE for medication orders, right? You go to CareTracker documentation. I do no longer go to CMS guidelines because those have changed and that hasn't been updated. But here's how you would actually accomplish it within CareTracker. Click on CareTracker documentation, and it pulls you to that section of the PDF, and now you can read about how you can satisfy that requirement within CareTracker. And so I refer to this all the time. It's always there for you. It's just fantastic. Okay. So in order to do CPOE, I've got my patient here in clinical today, and again, this is for the reporting period, right? So they want to see an appointment and an encounter based on the reporting period. So we're trying to qualify from October 1 to December 31, and now here's my appointment, and an encounter now is going to get tied to that appointment. Otherwise, I don't get added to the this patient will not get added to the denominator. Okay, everybody clear on that? So I'll click on Bach. Pops me into the medical record. To add a prescription, click on the RX writer. You can see that flash for the encounter, which is now getting tied to my appointment. Now I should have the dialog box coming up. I do. Lo and behold. Now if I fill this out, either by favorites, and here's my screening process. That's what we set for Objective 2, I believe that is, isn't it?
Yep.
Then benefit outweighs the risk. Like this. I see Stephanie's on board, so Stephanie and I just went through this. Accept, and then go through this and fill this out. Actually complete this order. I could select a SIG or go through here.
So basically nothing unusual. It's just using the script writer and use the script writer with tied to an appointment, and the doctor is going to be good. And like I said, most of what we're seeing is 100%. You're either 0 or 100%. It's got to be something weird that you started and stopped midway to not hit it. So how about the lab orders and radiology orders? How do we satisfy those measures for that?
Lab orders, instead of clicking on the RX, you go one to the right for this icon here for order, and this has both my lab here and my radiology here. I do not have to have, as Matt was saying earlier, I do not have to have interfaces hooked up to this. This is for computerized physician order entry, right? So they just want to make sure that you're actually using your electronic medical record to fill out these orders. And medications, labs, and imaging are all orders.
And do we have to send it or print it or fax it or just record it in order to meet the measure? Is there, or just simply create it and save it and you're good to go?
Create it, record it. So if you save it, it should be the same thing. But typically I put it on record. A lot of people have it on print. Once you click on save, it's going to print it, but that's going to mark it as recorded.
Okay, so super easy to do. And the funny thing about this measure, everyone, is the numerator and the denominator are nearly identical. So that's why you're going to get zeros or hundreds. So if you see a 0, it means you've not created an order for radiology or labs, or radiology or labs, or you haven't used the script writer tied to an encounter. So if you see zeros and you go in and you do one, you're gonna notice that, wow, I went from 0 to 100 by doing 1, and that is correct and that is accurate, and so kind of easy for you in that respect. Okay, I'm going to go ahead and take it back.
See, someone has
Stephanie
has. Do you have to check RX eligibility when ordering medications? Yes, you do. And that's later. We're getting
tight. We're so tight. In fact, I think we might almost be there. So that was objective 3. Objective 4 is Stephanie's question. So objective 4, and this is for e-prescribing specifically, what this is telling us is that on the scripts that you are writing, you need to at least 50% of the time check the formulary, which is basically hitting the check RX eligibility button that I have up on the screen here. And so, Brad, why don't we have you jump in? You can answer Stephanie's question as to how, and also explain a little bit about what they might see when they're popping in there. So let's get you back to, sorry about that. And Brad is the presenter. There you go, sir.
So if I'm going to check the RX eligibility, here it is right here. CareTracker, so if you've got the patient in the schedule 24 hours ahead of time, ahead of their actual appointment, CareTracker checks that automatically overnight, okay? If, however, you're under that 24-hour period, CareTracker does not check that for the appointment. And you have to then, go ahead, Matt.
And I was just going to say, so if it's been checked within 24 hours, what happens to that check our eligibility hyperlink that you were just showing us, the one in blue?
Yeah, the one in blue. So you got to click on that, and that's for renewals and for new meds. Okay? You want to have your health providers checking that. Furthermore, if you're going to have front office staff, pitch in to do this, and a lot of offices do, you've got to make sure that that staff member has the appropriate role of provider or mid-level. Otherwise, it will not count. Folks, everybody follow me on that one?
So our recommendation is when your providers are writing scripts, if they see check RX eligibility is highlighted, click on it. It just takes a second, and it solves the problem. Provider is checking eligibility, which is actually what that measure is asking about. All right, Stephanie, did we answer your question okay with that?
She has another one. What happens if patient does not have check RX eligibility available to check? So this link is always here, and whether or not the patient actually has an actual formulary or not, the program doesn't care. And so right now, for example, this patient, Johann Bach, he's dead. He doesn't have a formulary, and if I click on it, I'm going to get credit, and then it's going to come back. See, my link went away, and it's just simply telling me that this patient is not eligible in terms of formulary, but I'm still going to go send in his prescription.
So the reason it's not always there is not because the insurance wasn't playing along. It's because the system automatically checked overnight, and you can only check once every 24-hour period. That's why this went out. Now, if Brad checks back tomorrow for Johann Bach, that check eligibility is going to be available, and he could do it again. So that's why it's not always there. So if you see it, click on it. If you don't see it, then there's only two reasons you wouldn't see it. One is if your role is not that of a provider, you might not see it. But if your provider who's writing the scripts sees it, then you're good to go. Alrighty, so moving on. That was objective number 4, checking the formulary. And objective number 5 is the health information exchange. We refer to it as transition of care. This is one that most providers are going to fail for 2015 unless they get their direct email. However, you are able to exempt out or exclude if you have fewer than 100, which is very likely for a 3-month reporting period, because we're really talking about patients that have a transition of care type of appointments, which is usually a new patient or something like that. So if you're in a scenario where you're not planning on getting direct and you are wanting to attest this year, you got to make sure you have less than 100 transition of care appointments that come through in the reporting period. So the idea behind this one is that we're actually using direct messaging. Direct messaging is an entire United States sponsored by CMS and required for anyone meeting who is going to attest to sign up for and get a direct email address, then to use that direct email address from within your electronic medical records. That's the key, from within your electronic medical record to send and hopefully receive electronic information related to the patient care. Right now, this is measured by creating a continuity of care document, also called a CCD, and to actually send it electronically. So this one will be a little bit interesting until everybody gets their direct address. It's kind of hard to show, but Brad, can you show where you would go? It's going to look just like sending a to-do, basically. So I'll make you the presenter again.
So here's where the direct, so does everybody see this here? You see in my screen? Here's where the direct functionality is going to be. And so that so you could actually read your direct mail here. I could click on this, but right now it's not enabled. We're starting to apply for direct email addresses, which is provisioned by a government-sanctioned body.
But if you click on mail, that'll show you the same idea, right? Or to-do,
right.
Either one, it's going to be configured the same way.
Yeah, so if you click on a to-do, you'll click on this just as if you were going to send a mail up to the patient portal. This is where you'd actually, then there'll be a direct email here that you can actually send it to. Okay?
And how about creating the CCD? What about that?
So creating the CCD, so what you do here is you create a referral. Additionally, you would also have to have a referral in here, which you'd add an attachment here. Well, maybe I've got to let's get oh yeah, my patient is in contact. I'm going to link actually patient data, link patient data right there. And so what I would actually do is go grab the CCD, and I would include the CCD in this email.
And can you do that from linking patient data?
You cannot. You have to actually go into the patient and create the CCD there, and I'll show you how to do that. So now I've got it's in it. So there it is. It's an XML document. Extensible markup language. Gotta love that. And so how you actually create a CCD is you get into the medical chart summary, right, through Clinical Today. Click on the down arrow next to View and create, and click on CCD. And if the CCD has been created, it shows up here in this list. If it's blank, you're going to click on Current CDA or Current CCD. CDA the A stands for Architecture. Here it stands for Document. I believe that CDA is going to supplant CCD. It's a newer architecture. And so, click on Current CCD, creates it here. There you have it.
And once it's there, then I can grab it, include it into my direct email or my to-do or my mail within CareTracker. So again, take you back to the slide here. Thank you, Brad. It's about a patient who is going to be transitioning to a different setting. So if you've got transition of care type appointment is the first step. Second step would be creating a CCD, and then the third step would be sending it via direct. So if we think about next year, when you have to meet this threshold of 10%, we're going to be looking at how many transition of care patients you have, and you can run the supporting report in any time to see where you're going. 1 out of 10 of those is going to need a CCD created and sent to another provider. So yeah, there's ways to get creative with this later on if we get into a scenario where you're not finding enough providers with direct. I don't think that's going to be a problem come 2016 because there's still a majority of providers with EMRs are actually going towards meaningful use and getting the direct messaging email address. So we've sent out information to everyone on how to apply for that, and we welcome your calls if you need help to get that done. If you get the email address this year and activate it, you're covered. Next year, you have to hit the threshold, basically. Okay. Objective 6, patient-specific education. So on this one, this is not a new one. It's still in here because eventually this is going to be about moving patient education up to the patient portal. But for now, in order to meet the objective, you need 10% of your patient visits need to have patient education printed. And there's a definite way. I've got, and again, the key is printed. And I've got on the screen a little screenshot of when you're in education, and there's a little print button at the right. So Bradley, I'm going to switch to you if you want to walk us through inside of CareTracker how you meet this objective by printing patient education.
So within Clinical Today, click on my patient name. Click on educational materials here. This is taking me direct to my favorites. And as long as I select one and then click on print here, I'm going to get credit for printing educational materials for this patient, for this visit.
Super easy, right? Super easy. Just got to print it.
And one of the things I like to do too is show that in here, if you're in here, I'll go to all adult, Let's put in gout, search. I can even print checked here. Don't have to even print it out.
So no wasting paper, no faking it out, but you get credit for it. So this one is, I think a lot of practices are actually using the patient education. Now, whether they're using it from CareTracker or still pulling out a piece of paper from the file, but the idea is leveraging CareTracker and, like I said, eventually going to where these are uploaded to the patient portal as opposed to printed. But right now you're getting credit just simply by printing them. Okay, that was objective 6. So objective 7, med reconciliation. And Bradley, I might point out we're at like getting to be only about 15-20 minutes left. So if you can move rapidly through those so we have time to cover PQRS. This one is med reconciliation. It applies only to transition of care patients, just like some of the other. And essentially what's happening is we need to mark the medications as reviewed and then create a CCD. So we already showed you the CCD. You want to show us, Bradley, how to mark medications as reviewed? There we go. There you go.
So you, from Clinical Today, get into your chart summary, medications, click on Mark Reviewed. There you go. I am now going to be counted.
And that's critical there. If you don't get that pop-up for transition of care, then it wasn't a transition of care appointment. And if you don't click yes on that, it's going to be a transition of care appointment that you don't get credit for. So super critical that you, along with marking reviewed, you take the time and make your providers know that that second pop-up box totally determines whether or not it triggers for that scenario. So you could be, if you weren't saying yes on that last pop-up box, you could be doing all the work and getting none of the credit. Anything else on that one, Bradley?
If there's no known meds, there'll be a button to click on for that.
Got it. Okay, so that's objective 7. That one hasn't changed a whole lot other than now it's transition chair only. So objective 8, this is patient electronic access. This is all about the patient portal. The first part of this has a very high threshold. 50% of your patients need to be signed up for, within 4 days of their appointment, the patient portal. And you can actually do it for them. The patient doesn't have to do a thing. You can, just by registering or pre-registering, you're going to get credit for it. Everybody, it's not just new patients. It's every patient. So if you've got patients who are repeat patients, and it's the first time they're being seen during this attestation period, you're going to have to make sure that they're already registered or pre-registered, and if they're not, you're going to need to do that on their behalf. The second half of this has to do with the patient viewing, downloading, and transmitting, DDT. And that is right now only one patient has to do it. So a lot of practices are just getting a patient who is willing to help them actually log in to the patient portal while they're in the office, and you kind of use it as education. You show them how they would view, download, and transmit this. So Bradley, I'll switch it over to you. Okay.
So here you're actually seeing my health tracker screen, and here's the DDT button right here in the health record tab. So the patient signs in, they go to their health, they navigate to their health record tab, they click view, download, or transmit, and this is, again, as Matt was saying, assuming that you've created a CCD, as we all saw. If you want to register your patient, you go to Patient, Practice Details, And if this button is yellow, all you have to do is click on it, active, registered for this group, you're going to get credit, as long as we're talking about an appointment, once again, within the reporting period.
Thank you, Bradley. So if we see active or pre-registered, we're good to go. All right. So, Objective 9, secure messaging. So this is the ask to practice objective for and I'm not sure who's calling in. We've got a little background noise. Okay, thank you, whoever that was. So Objective 9, secure messaging. This is the ask the practice objective. For 2015, it's just enabling it, turn it on, it's self-attestation. The expectation is that is going to change to a threshold in the future. But for right now, what I've got on the screen here shows you in the setup for the patient portal, you're going to want to take a screenshot of this. Now, this one wouldn't pass because Ask to Practice is not enabled. So, Bradley, I'm going to do two things here. I'm going to show Objective 10 as well, and then I'm going to have you cover both of those at one time. So we've got the Ask to Practice, that's part of it. The other part of this is the immunization registry, which if you administer even one immunization during the reporting period, you have to be actively engaged with your state immunization registry. So that means you have to get the to-do sent to us that we are turning it on for you. For 2015, you just have to be actively engaged. For 2016, there will be thresholds you need to meet. The second half of that is syndromic surveillance. This is basically running reports and submitting. Most of the states aren't ready, so both of these can be kind of easy. They'll be self-attestation, and as long as you have the capability of syndromic, which you do, or if you're submitting, if you are administering immunizations, as long as you're engaged with the state, you'll be in good shape. So, Bradley, I'm going to go ahead and switch it over to you.
Okay, so secure messaging, we just went over, basically, but this is where you can do it in the portal right here. You sent the patient would send in a message, and you would monitor that on your home screen over here. Okay. Let's see. Now we're talking about immunizations.
Yep.
So immunizations, if you do any, then you've got it. There's nowhere to actually do that. I mean, you don't actually set that up in CareTracker yet in terms of electronic messaging, but you've got to be in. You've got to actually show that you are in a meaningful conversation with the state registry to send that information in.
So proof of that would be the copy of the registration material you filled out with the state, and we can provide copies of the to-dos that you have for CareTracker turning it on. That gets you engaged. How about syndromic surveillance?
And in Colorado, syndromic surveillance is not ready for prime time, and so when you're actually attesting, you say, "Yep, I want to do that," but then there's an option to say, "My state is not ready." If you're in another state, such as California or Wyoming, you need to check that out and make sure that that is something you can or cannot do, and then you would do the same thing you've done with.
So if your state is accepting syndromic surveillance, a to-do, we'll get CareTracker to start working with your state. They probably already are, and have that turned on for you. So let's say that your state does participate. Then it becomes running the CQM reports. Is that correct? And uploading those.
I'd have to check on that. I'm not sure, actually.
All right. So basically, having it turned on gets you satisfied for 2015.
I think it's really just you have to show that you're in active engagement to submit data to a specialized registry.
Okay. All right. So let's try to summarize this. So the tools that we have in CareTracker, Brad's already spoken about those. We've got the dashboard, which will allow you to run the underlying report. You can also go to reports and run the individual reports. That's what we're doing right now as we're monitoring the various different meaningful use progress that each practice is making. If you are participating with that, you'll get a report from us twice a month with your progress. The other tool that resides in CareTracker from the dashboard is that CT documentation, the CareTracker documentation, how to actually click the right clicks to make sure that it is showing up. So that's CareTracker tools. Let's switch gears here. We've got a few minutes left. I want to cover PQRS. So for 2015, there are, and actually for every year for that matter, there are 3 types of reporting options available to you. The first one is claims-based. You would have had to have been doing that all year in order to take advantage of that. The downside of claims-based reporting is there is no way to validate whether you've sent the right things for the right encounters on the right claims the first time to Medicare. And so you're certainly welcome to do that. And if you've been successful in the past, you can just keep cruising with it. Now that it's turned into penalties instead of incentives, my recommendation is to use the registry to report, and you can still report on individual measures if you want, which is the way that claims-based reporting goes. If that's the case, you're picking 10 measures spanning 3 domains. You've got on every single patient that had a visit, you're going to have to answer questions in the registry. The easier way to go is selecting a measure group. So a measure group basically gets very, very deep into one specific topic, say preventive care, or maybe managing diabetes. And when you select a measure group, you only need to report on 20 total cases, 11 of which have to be Part B. There's a third option, which is called the EHR reporting, and that is coming. That's what the CQM reports are enabling you to do. But for now, we recommend the measure group reporting, and it just is your best option all around. The penalty for not is 2%. That'll be assessed in 2017. And that's every year you don't report, the 2 years later you get the 2% penalty. So if you take our recommendation and want to select a measure group, you would pick your step-by-step process here is number 1, and we'll send out to everybody the measure groups that are available. Pick a measure group that fits your practice. Alternatively, if you can't find a group that works, pick 10 individual measures crossing 3 domains. Try to find a measure group. You can talk to your specialty trade organization, and they can help you decide what other people in your specialty have been selecting for measure groups. Basically, once you've done that, you want to sign up for a registry. We're going to send out the CMS list of certified registries. What I would look for in a registry first and foremost is, do they support the measure group that I'm selecting? Secondly, I would look at the cost. And thirdly, I'd look at geography. If it's someone close or maybe just the specialty group that the registry is servicing. But basically, once you select a registry and a measure group, then what you want to do is sign up for that registry and sit tight, finish your billing for 2015, and then sometime in early January, you're going to want to run your PQRS reports. The only reason you're running those reports is to get a patient population that you're going to pick from. You want to pick 20 patients at least. You can do a few more if you want. Pick those patients that have the best data set, and then you're going to manually log into the registry, manually enter patient information, their date of birth, their address, their insurance, the dates of service they had, and answer questions based on the registry. All right, so that's kind of the real quick on the PQRS. We'll send out all of the information on the measure groups, the registries, and as well as this slideshow that'll give you the step-by-step process. A quick word about the clinical quality measure reports. Brad showed you as one of the objectives where those are run from within CareTracker. You basically, the need to know here is that you're going to have to, from time to time, run some of these to get denominator and numerator information for attestation. If you're going the individual measure route and doing registry reporting, you could leverage these reports for that, although it doesn't get it all done. And eventually, when we get to EHR reporting, which is going to be a stage 3 requirement, these reports will actually be used in lieu of all the other methods of PQRS reporting, hopefully making life a little bit easier. Bradley, anything you want to mention to kind of summarize all this? And then let's open it up to any questions that people may have.
Just that what we're starting to see with some of this stuff now is that the data that we're putting into the EMRs is starting to become more and more important, because instead of pay for, fee for service, is going to be pay for performance. And to bear that in mind as we go down this path, that even though that, as they say, they're topped out on, for example, smoking measures or vital signs, that you want to keep collecting that data, because that's, as we were just showing you here for the PQRS and for clinical quality measures, CQMs and stuff like that, that's going to become key.
Now, there's a question, if you can go back to the previous slide.
Sure.
I think it was the one before this one, if I'm not wrong.
Can you ask that again?
I think it might have been the one, it's from Sun. Is it the one before this slide? Yeah, there we go.
That's Stephanie.
Oh, it's Stephanie. We're sending this out. You don't need to scribble it down. You're welcome to, but you're going to get via email this slide presentation with all of this already written down for you. All right, other questions? So I think the key here for everyone is to try to be ahead of the curve a little bit. Look at your reports now. We have that monitoring service. We're happy to do this on your behalf. If you take advantage of that, you're basically getting free hours that more than cover the work that you would be doing. So we want people to sign up for it because we want you to be engaged and be in the conversation with us and know on the different items what to do to increase the numbers. Again, it's kind of lucky this year. There are several of those measures that will be threshold items next year, but for this year, you just have to have the capability. So we're really talking about concentrating on orders, patient education, e-prescribing, and checking that eligibility before you do before you actually create the prescription. It's stuff that is kind of in and around what you've been doing, but to make sure you're doing it in the right order at the right time, like activating those patients within 4 days of their appointment.
Yeah,
so
that's
easy
a big
to
one.
do.
And the eligibility, the formulary, the eligibility check has been a big bugaboo. as I've run
So
these.
easy to do. All right, so thank you, everybody. We appreciate your attending. Tony will be sending out all the materials that you've seen, plus several items I've referred to, but didn't show you during the call. So thanks again, everybody. We appreciate it.
Thank you.